Vishali Prasad. I'm on a faculty at Family Medicine and Community Health. I'm the director of the Global Family Medicine at the University of Minnesota. I'm also a faculty at the North Memorial Family Medicine Residency Program. Today's theme is going to be capacity building in primary care and community health in East Africa. We'll introduce our speakers one after another, but to begin with, we have Ben. Ben Henkel is a second-year resident in internal medicine here at the University of Minnesota. He's originally from Illinois, but has been all over the Midwest. That's what he told me. With an undergrad from University of Wisconsin and an MPH from the University of Iowa. He went to med school at the University of Southern Illinois, and he decided to come to Minnesota, which is the best place there is, right? So he's going to give us an update. We call it the Global Health Update. Ben?
Second-year resident, University of Minnesota in internal medicine. And I've been tasked with the Global Health Update for this session. So we'll start with a case. The time is, this is a hypothetical case, but based on a real. So take yourself back to the spring of this year, March 2015. You're in an emergency department, could be anywhere in the city. And a 60-year-old male presents with a confluent, slightly pruritic erythematous rash on his face, arms, trunk, and legs. He has associated fever to 38 degrees Celsius, conjunctivitis, weakness, and edema of the hands and feet. Symptoms started 4 days prior, and on further history, he reveals to you that 4 days prior, he had also just returned from a 12-day trip to Brazil. So what kind of differential would people think about here? Just shout things out. Okay. Anything else? Dengue, yeah. Yeah, chikungunya. So, other things that were tested for: Japanese encephalitis, HIV, HHV6, and then Zika virus, which is what this gentleman was diagnosed with. And that will be the topic of today's Global Health Update. In this case, it was actually based on an Italian gentleman who presented to an emergency room in Florence in March of this year and then was subsequently diagnosed with Zika virus. And so currently there is a Zika virus outbreak in Brazil going on. And this is notable because this is the first time Zika virus has been seen in the Americas. Investigation started early this year in February or so by the Brazilian Ministry of Health. And that was after almost 7,000 people had presented with a mild febrile illness with rash. And they started investigating this. Then on May 7th, the Pan American Health Organization and World Health Organization issued the first epidemiologic alert. And then a week later, the Ministry of Health in Brazil did confirm 16 locally transmitted cases of the Zika virus. Europe and the U.S. followed suit, issuing their own risk assessments, and basically to increase awareness that Zika virus has spread to the Americas, and you need to be aware of this in returning travelers. Unlike some past outbreak talks that we may have had, like chikungunya, this is kind of the extent of information available. There still have been more cases confirmed in Brazil subsequently, and it's ongoing, but complicated somewhat by similar presentation to dengue, which is also endemic. So, I didn't know much about Zika, or actually anything about Zika before putting this together. So, we'll do a little history and background and kind of work through it together. So Zika virus is an arbovirus of the flavivirus genus. It was first isolated in rhesus monkeys back in 1947. And this was a monkey that was a sentinel animal in yellow fever study conducted by Rockefeller Foundation. And they basically put the caged monkey on a platform in a tree in the Zika forest of Uganda. And it became febrile. They drew sera and then injected it into mice, and then 10 days later, as the mice became more sick, then they necropsied them and eventually isolated the virus that became then known as Zika virus from brain tissue, actually. Subsequently, the next year, it was isolated in Aedes africanus mosquito, and then humans in 1952, both in Uganda and Tanzania. Then this is 1956, it was found in Aedes aegypti and has subsequently been found in numerous Aedes species. And then from about the 60s until the 2000s, it really was isolated to countries in Africa and Asia with intermittent travel-related cases around the world. So it's transmitted by the Aedes species of mosquitoes, and numerous different species have been implicated, but most notably is the Aedes aegypti, which shares the ability to transmit dengue, chikungunya, yellow fever, and Zika virus. They're notable to be primarily daytime biters and feed both indoors and outdoors, and this would be maybe in comparison to something like Anopheles, which transmits malaria, which would be more of an evening or night biter. And then the reservoir is thought to be primates, both non-human and human, and in outbreaks they have documented vector-human or human-vector-human spread. There has been some research that has shown antibodies identified in rodents, but how they're relevant to the whole picture is still unknown. And then you can see the distribution of Aedes aegypti down below, which is quite widespread, and we'll kind of talk about that a little more. So the clinical presentation, only 1 in 5 of infected actually present with symptoms. So it has an infection rate less than 20, or symptoms only are identified in 20% or so of those that are infected. And the symptoms are fever, rash, arthralgia, conjunctivitis most frequently. But headache, retroorbital pain, edema, and vomiting have also been noted. So usually it's a relatively mild clinical illness, just like they saw in Brazil, where there was those 7,000 cases of fever and rash-related illness. And the symptoms last several days to about a week. And this can be in comparison to something like dengue, which probably has a febrile period similar, 5 to 7 days, but then can also be associated with several more days or weeks of general malaise and fatigue, where this usually resolves. And similarly, chikungunya, in comparison, would also possibly have a more protracted course. There are some more severe complications like Guillain-Barré, meningoencephalitis, thrombocytopenic purpura, and leukopenias, but no deaths have ever been reported directly related to the Zika virus. So diagnosis and management, it's basically clinical diagnosis of the viral prodrome and then knowing the geographic distribution of the virus, which we know now is changing. And they note that it's most important to consider other viruses or diseases that can have much more severe outcomes like dengue or possibly malaria, and those should be obviously ruled out first. Serologic diagnosis can be made ideally by PCR, though there's no commercially available assays available, and there are some ELISA assays. No specific treatment, just symptomatic management. And then there also can be co-infection. So there's been reports of Zika and dengue co-infections. And how that relates to disease severity is still being investigated as well. And there's currently no vaccine. So recent spread of Zika virus, kind of just to review this outbreak and how did it land exactly in Brazil. So as I mentioned before, from the 50s or 60s to 2000s, it really was isolated to Africa and Asia. Then the first major outbreak was in the island of Yap, or Micronesia, in 2007. And approximately, they estimate 900 people, around 900 were affected, and they did have 49 serologically confirmed cases. And to put that in perspective, the island of Yap has only about 7,000 people on it. So it was fairly widespread outbreak. And there's actually a New England Journal of Medicine article in 2009 that documents this outbreak quite well. In 2013, there was another outbreak in French Polynesia, and I saw one paper, 10,000 up to 19,000 people were affected, and French Polynesia is multiple islands, but about 270,000 people in total. So kind of spreading through the Pacific Islands. And in 2014, there's been cases in New Caledonia, I think like 80 confirmed cases as of May of this year, in the Cook Islands. And then most recently, it's been confirmed in Easter Island off the coast of Chile, and then now has arrived in Brazil. So if we look at this spread, I found, so in review, this is just another graphic displaying its kind of migration from Central Africa now to Brazil. And one interesting thing to note is, how did it get to Brazil? And there's some speculation. They think cases were first probably there in 2014, and they mentioned the World Cup as a possible mode of transmission of how it's arrived there. So if we look at what countries are at risk now that we've spread to the Americas, I think looking at the countries or regions that are that have Aedes aegypti would be most appropriate to predict maybe where this could spread. And I found striking resemblance to the chikungunya recent outbreaks when reviewing this literature. So chikungunya from 1950 to 2013 was restricted largely to Africa and Asia. And then in the last 2 years has followed a very similar path that Zika is following right now, across the Pacific, landing in Brazil, and then migrating up into the Caribbean, and then U.S. So this is the current distribution of Zika as of May of this year, with Brazil being the latest location of outbreak. So what are the public health implications of this relatively mild febrile illness spreading? And really, two things come up. And one is any place that has competent vectors could possibly become endemic in the future. So Aedes mosquitoes geographically reach both into the United States and into Europe. And so both places are concerned that returning travelers could infect the local mosquito population, and then it would become endemic in those areas. And things that could perpetuate that are only 1 in 5 people present symptomatically but could be carrying the virus. So I think that could complicate things. And then there's multiple species of Aedes mosquito that could perpetuate the infection. And then the other big thing is this is a third virus now that people will present to healthcare resources with infection. And so there's a much greater burden of disease on places with already limited healthcare resources, like in Central and South America and the Caribbean. So those are the two major things that I think were brought up. And then of note, there are severe outcomes like Guillain-Barré and encephalitis. They brought up some concerns about blood donation and whether it can be transmitted through blood donation, but there's been no documented cases of that thus far. There is some reports of sexual transmission and perinatal transmission as well. So basically, what are we doing to prevent this? And it's basically awareness, vector control through environmental management and mass sanitation, getting rid of those breeding sites, the old tires and such. And then awareness, both for travelers, patients, and providers. So for us, it's knowing that if we have a person coming from South America, that this should be in our differential. But definitely we would rule out probably dengue first. And then also promoting, if you're in travel clinic and sending someone on a trip, definitely reinforcing that this is now another risk mosquito-borne illness, so be extra vigilant with your personal protection. So with that, any questions or comments? That may be the extent of my knowledge on Zika. Yeah.
I may have missed it, you may have mentioned it, but how do you diagnose it? Do you have antibodies or how do you
So there's PCR is clinical presentation and travel history or being in the geographic areas initially, and then they prefer PCR, and there is I saw mentioned ELISA assay as well, but there's no commercially available kit available that at least that I could find.
so order Zika PCR?
Yeah, I believe so. Okay. In the back. I have not. I did not see any numbers, but it in the list of countries that have had returning travelers, over the last 50 years or whatever. The U.S. was listed, but I'm not sure.
Thank you, Ben.
All right.
So it gives me great pleasure to introduce our next speaker, Bruce Dahlman. I'm actually happy that he's here because he has a very interesting nickname. It's called Buona Safari, the man who likes to travel. I was at a recent American Academy of Family Physicians Global Health Workshop, and people are disappointed that I'm from Minnesota and Bruce was not there. Very popular in that world, primarily because of the different activities that he's done. Did his undergrad here at Bethel University, med school at the University of Minnesota, did his family medicine residency at the University of North Dakota, and then started traveling. A lot of work in rural Minnesota, was in family medicine residency training as a faculty at the Duluth program. And then subsequent to that, he's had multiple visits, primarily to Kenya. He's worked primarily in Kenya for many years. He's been associated with a group called InfoMed that's been associated with developing family medicine and primary care in East Africa, particularly Kenya.
Thank you very much. Thank you for that nice introduction. I want to dedicate this talk to a mentor of mine. 1980, fall of 1980, I was in a seminar sitting out in that audience, listening to the leader of the then Tropical and Travel Medicine series, being held by Dr. Vince Hunt. And he was one of my inspirations to consider global and continue on working in global health. And yet he comes to hear my talk today. I want you to stand, Vince. You're Dr. Hunt is a legend. If you call me Buona Safari, you have to call him that squared. This guy's been not only traveling around the world, but has probably started more family medicine programs in different countries around the world than most anybody on this planet. He's a very, very inspirational person to me, and I want to thank you, Vince, for all the encouragement you give so many people. Thank you. So my topic tonight is to look at some issues around trying to build capacity in the majority world, is how I like to call it. The majority of people living in those less than, how do I put this, resource-challenged areas, perhaps. Another way I describe this area of the world is that they're the relationally developed world. And any of you who have worked cross-culturally, I think, probably know what I mean. I like to think of it in the positive because they have a lot to teach us, and I've learned more and go back to learn more each time. So I am the director of the Digital African Health Library, which is a part of this talk, and so you'll note that I haven't made any money out of this thing after working at it for 10 years, but hopefully someday it'll become at least viable. So question first to you all. Those of you that have worked cross-culturally, clinically, how many have worked in Asia doing clinical care or some connection to it? Yeah? Okay. And Africa? Okay, good number. South America, Central America? Actually less than Africa? Really? Wow, that's pretty cool. So how many of you have had situations where you're trying to find out something to help take care of patients and you didn't have the internet? Yeah, raise your hand. Yeah, almost all of you. So what resources did you use? You had a patient-prompted clinical question. You know, William Osler is famous for his quote, well, listen to the patient. They're telling you what the disease or the condition is, right? So you're listening to that patient's story, and your mind is whirling about what might be going on, and you have a question that comes to your mind. Now where do you go to get that answer when you're in that setting where you work? Just call out what kinds of things you use. Sorry again? Books. What kind of books? Oxford Tropical Medicine. How many have used it? It's gold. You got to have it. All right. Anything else?
Somebody else.
Sorry?
Somebody else.
Somebody else.
Another.
Another person. Yep. Excellent. And don't forget it. I mean, they're the experts in their own communities, and ask them. Ask the consultant or the nurse. You know, the nurses know a heck of a lot. Absolutely. Good. Any others? What did you put in your pocket? What did they tell you to put in your pocket to bring with you when you went? You're just relying on your head, huh? Okay, well, those are a couple of the resources. Those are the issues that I've been dealing with, in my medical education work too. Challenges and barriers to getting to information. Name a few of those. Electricity. Pretty basic stuff when you're out there in the bush especially. And internet, well, there's no power today, sorry. What else? Other barriers to getting to information that you need? Subscriptions. Okay. Costs. Yep. Time, getting to it. The time it takes to get the information. Yeah, big barrier. Okay. Cultural differences in terms of how the questions are phrased even, or knowing where to look. Okay, good. Big, huge demographic differences. You might find information, but it doesn't have anything to do with your particular area. So a lot of the studies, journal literature, what is it, 800,000 copies in Medline every year now? But how many of those originate from the areas where we're from and working? So the data doesn't necessarily correspond. Okay. Yeah. Nobody said internet issues yet. I can't believe it. It's getting better. All right. I'm in Nairobi now. This was just last couple months, and you can get 4G in Nairobi. It's not bad. Go step 1 foot outside. Yeah, you're back down to your 2G edge. So looking up something real time, kind of dicey, costly. Internet cuts out. I gave a test a week ago to the incoming class of family medicine residents, and one of them was downloading their test on Blackboard and got it halfway done and did half the test without knowing he didn't have the whole test. And when he went to refresh it, blitz, all his answers went away. So yeah, internet issues, big issues. Okay. Yeah, so would they like resources in terms of trying to help their patient care? Yes, they would. So motivation, you've seen this statistic probably before, that Africa is one of those places where there's lots of disease going on, but so few resources, both in terms of the health workforce and in the actual material for carrying it out. So can health information decision support be at least some potential help to them? That's the question. So another motivation I had for the study I got involved in is that I'm in family medicine education. Why family medicine? Well, in East Africa and most of the sub-Saharan countries, medical education is the 5-6 years after high school, and then you get posted by government after internship out to a bush place. Half those, in Kenya anyway, half of those students went through their internship at a huge hospital, the major national referral hospital, or somewhere where they actually had no skill training at all because somebody else was in the pecking order ahead of them. Does that sound familiar? Yeah. And so they don't learn their C-sections or their emergent surgeries like they're supposed to. And when they get arrived in the bush hospital in Kapenguria or in Lamu somewhere, somebody shows up, usually the first week for a C-section, and if not the first night, and the nurse is basically teaching them how to do it, where to put their hands, what to do. Well, that kind of training, it gets you pretty scared pretty quick. And so when people ask me, how does this family medicine thing, figure next to the medical officers that we're already training? There's no difference, is there? And all I have to do is ask them a question. I said, where did you do your training? Yep, in that big hospital. Where did they send you the first posting? Yep, out in that rural hospital. And I just ask them, how did you feel after being there for 1 month of being in that rural hospital? And you know what? I've asked probably a couple of dozen Kenyan doctors that. None of them answer me. They usually raise their eyebrows and say nothing, which is to say something's not to talk about what happened during that first month after they got out there. And in a shame-based culture, I know not to ask the next question, would be, well, what happened during that month? You can't ask that question because that would shame them terribly for what probably they don't want to talk about. So those are the issues. They're not well trained. They don't want to stay out there because they don't feel adequate. So what do? They want to leave as fast as they can. They want to run to a specialty because then they don't have to know so much, supposedly. And so those are the pressures that have been keeping the workforce difficult for primary care. So we started primary care training for family medicine in about 2005 in Kenya, previously in Uganda, and now since some other countries. And we wanted to do a learner-centered approach that used the patient-prompted questions as what they were learning by. Try to take Osler's word and ask the patient to be our teacher. But there's the information divide, the availability of locally relevant materials, and there's the internal digital divide that Ryan has talked about, where the internet and other fancy ideas about how we can get information are basically just not possible. And of course, if you've been to anywhere outside our well, how do I put this gracefully? Our cultures that are so bent on efficiency and productivity, and you go anywhere else, and it's all about relationships. These are the people that I live and work with for the 13 years that I've worked in Africa. And these South Sudanese doctors, if I had time, I'd tell their whole story. But the one on the left in front of me there, Samuel, is now a resident in our program. A story where he learned his initial 5 grades were in Juba Arabic, and his next few years were in Ethiopian refugee camp in English. And then the Spanish came, the Cubans came from their country to help out in Ethiopia, and anybody who could speak Spanish well enough would go there. He took his medical training in Cuba, and then he was a refugee in University of Calgary, in Calgary, Canada, and then from there came back to Kenya for an internship after restudying English for his medical school. An amazing man who, during the troubles in 2013 in his state, Jonglei, had to run for his life across the river, and when he got over there, there were 20,000, 30,000 refugees waiting for him to take care of as one of the few, if any, physicians. So there's amazing people that we work with and that teach us as well. So these are groups that I've been working with to try to help develop something that would help give us information at the point of care so we can both learn, teach, and take care. So during my Master's in Medical Education, I developed the Kenya Health Information Study. We'll go through some of those data. Rwanda followed afterwards. Then we did a prototype, and then as of a couple months ago, we actually have launched the initial subscription version of the Digital African Health Library. So we wanted to ask some of these questions around how primary care clinicians access information, and then see if we couldn't bridge some of the gaps that we were finding, utilizing kind of leapfrog technology. Forget the computer, forget the wired internet. Let's put it right in their pocket when they're next to the patient. So the Kenya study was over 9 months with 8 family medicine registrars, as we call the residents there. In Rwanda, it was with 55 postgraduates, that basically anybody who wanted to in their postgraduate training programs. These are just some of the cohort data from those 2 studies. And we're basically using a Pendragon database in the PDA to collect answers to 9 questions around how information was being prompted or utilized. And then in Kenya, we got over 1,200 question-asking events. So trying to ask them to put in, when they got done asking a question of themselves for patient care, what were you using, what were you thinking, and so forth. So it's actually, when I did my literature review, it was one of the first, in fact, at the time, 2010, the only quantitative study that I could find in the literature. Unfortunately, I never got a time to write it all up and get it published, but here's some of the data. The format that people were using before they had a PDA in their pocket, basically the print literature and the internet, computer, and colleagues. Afterwards, you can see that once it was in their hand in a PDA, we use as a surrogate for a smartphone, 42%, so getting close to half the time they could answer a question using what they had in their hand. And most of that transfer was taken away from the same digital media, but that they'd have to go back home or to the library, if it existed, to find. So this is the same question in the Rwanda data. Again, from 7 to 58% of the time they could use that portable format. So what kinds of data were they finding and using? Well, you can see that handbooks and textbooks and a database, we used one called Dynamed. You probably know of it. UpToDate would be another electronic textbook, not quite the same type of resource. But those are the things that we had available, which they then were able to utilize. So some of the outcome data is looking at how long it took to them to get to their search, to find an answer. Well, it's good to know that when colleagues, i.e. your consultant, is along with you on ward rounds, that when they're across the bed, they'll actually answer a question at the point of care, 69% of the time anyway. And the PDA, up to 43%, and notice that the use of computer, internet, or print is almost non-existent at the point of care. You'd hope that there would be some print use, i.e. you'd have a handbook in your pocket, which works for single specialty people, but for our family medicine folks, when they're on call, med, peds, surgery, OB, orthopedics, what else? We're up for the whole gamut. So you can only shove two books in your pocket. So that was another motivation for trying to get something a little more compact. So this is another way of looking at the same data, home, hospital, or point of care. And what did it do? What's the payoff question? So this one was our, to what extent did knowledge gained from the clinical decision support alter prior plan of care? So it's a self-report of whether what they had in mind to do with the patient was altered by what they found once they accessed the resource. So you can see that colleagues did alter outcome. That's job security for us consultants that are working. That's good. PDAs, you can see altered outcome to the point where it significantly changed the patient's outcome, actually, in 4%, and then another 20% significant change in their plan. So you can see that all of them made some difference. So it's not like having it in a PDA was the only way that it did it, but by having it at the point of care, now the patient actually is getting the benefit. Most of the time, especially if it's an outpatient, you can look up that answer at home, but patient's gone, they never get the benefit of what you've just learned, and you have to save it up for the next time. So it's the difference between just-in-time learning and applying that new learning versus the just-in-case, I see it again in the future. So in terms of our methodology for education, the just-in-time is what we, especially in postgraduate care and into clinical care as consultants, are most likely to be utilizing. So our basic conclusions were that the use of the smartphone as a tool is a no-brainer. It took them about 2 hours for me to show them how to use a PDA, and they were off and running. And you can see the study carried on for some months with no real issues. I wasn't on site to even help them with questions. Patients significantly benefited when the smartphone brought answers to the point of care. And you can get a lot of information packed into these phones these days. That used to be a concern when I first started into this business back in the 90s when I was teaching in Duluth in family medicine in the residency. Had to write a grant to buy the first PDAs, and mine was the Apple Newton is the one I started with. And then buy the resource. You could get one formulary on a Palm when they first came out. That's all you could get on there. That's all the space there was. And these days, of course, we're up to gigabytes of data. So we followed that on now with all the information learned from those pilots, and did a prototype with 159 docs and med students in 5 countries using their own smartphones. Now there are smartphones basically everywhere. I think Kenya's up to around 60% penetrance with smartphones. So it's they're not behind us by any means. In fact, they're paying all their bills by phone. We're still figuring that one out. So we're distributing through University Connections, which was okay, but there was poor documentation of where they all went and who it went to. And so I didn't get a great consistent follow-up from those folks as much as I tried. And then we had to end up doing an IRB ethics review at every university site we were in. I tell you what, if you're going to do multi-center research, don't go through the universities. It's a bear. Because every one of those IRB boards, they take months. They don't take weeks. They take months. And so this study carried on for a couple of years to get what little data we did. The support was through the University of Calgary and some money through something called Grand Challenges Canada and the supporting universities. So here's just a little prelim data from these 159. Actually, there's the number 159 is who got the prototype, and I got responses from about 50, so about a third. And you can see that owning computers and bringing it to work and accessing the internet, it's there, but the internet isn't all that reliable and fast. And there's my distribution of countries. And I had to ask the questions a little more generally because they're responding to a survey rather than me collecting data at point of care like I did during my master's study. But you could see that there was use of databases and guidelines, handbooks, things that were available in the resource were basically used at the point of care. And if you look at how they thought it helped them, most were agreeing either strongly or that should be strongly agreeing or agreeing that the digital library had the right sources and helped them and made changes for their plans sometimes, and did change outcome in some as well. So it was carrying on with basically what I'd learned as well in the earlier studies, but with a little larger N. So the features of this is that it's either a smartphone or a tablet, iPhone or Android, can search across all the text at once, doesn't need an internet once you've downloaded the resource, and it basically can incorporate guidelines from the local resources. So we have, in fact, set up the Kenya guidelines with agreements with the Ministry of Health of Kenya. We have the Kenya clinical guidelines and the HIV testing and counseling guideline, and we'll, as soon as we get the funds, put their treatment guidelines in, again, which can all be searched across the whole thing. So here's basically the list of our resources. Each one of these manuals from Oxford, Tropical Medicine as the example, $35, $40 a piece. And so they can add up pretty quickly if you're going to try to bring a library out. And British National Formulary is a standard on our side. Dynamed is the journal-based integrated resource we use and feel it's probably as evidence-based as there can be, and surveys our literature from the majority world quite well. We use the CALS emergency management. It's the only place you can use CALS on your phone, as in Africa. And there's Africa Health Continuing Ed Journal and some WHO handbooks, which we hope to come as soon as WHO will give us permission. So the last one is the only resource that we've put into the library, which is needing an internet connection, although in very slow, small bandwidth. It's a differential diagnosis generator. Either you put in the signs and symptoms, and it gives you diagnoses out. There's quite a few programs like that, but the engine that runs this one uses prevalences and probability statements between signs and diseases that are all from Africa. So when you're putting it in here, it actually knows that typhoid perforation might be one of the things you have to consider with an acute abdominal pain. You wouldn't find that in a U.S.-based database. So it's actually improved in the India study, diagnosis by clinical officer or PA type people, from 52% to 85%. It didn't go 100 because the inter-rater reliability of the two consultants looking at the diagnoses of patients was only 85%. So it basically took it to what is as good as it could be. So it is a very powerful resource, which gives within 10 clicks is about the average it takes to go from, first inquiry to the initial review of possible diagnoses with a probability estimate for what they think it is, 80, 60, 40%. And then it asks you which questions it tells you which questions you should be asking to follow it up. You reanalyze after you've entered those, and it'll give you even better prognostic probability. It's going to be a powerful resource, especially for the nurses and the PA, clinical officer type folks that are at the front line that are making their diagnosis incorrect half the time. That means the resources that Africa can at least afford to misuse are being, in a sense, given for the wrong reason. If you can't make the diagnosis correctly, you can't give the right treatment. That means we're not doing very well with what little we have. So that's, to me, where I think we can make some of the biggest differences. So I don't think we're going to have time for this little clip here. Or are we? I don't know. Charlie, what do we got? We do. Okay. So this is just showing a little bit of the features of the search engine itself. And you can go on the internet and look at this. MedHand is our partner from Sweden that has been doing all the manuals from Oxford for the past, 10 or 15 years, I guess. And so this is the partner we have working to get all of these resources in. The problem is the programming is in XML, and most of the resources come in a PDF. So our expense and cost is doing all that translation work from PDF into the XML. And then from there, all the compiling that's needed to make sure that it can be searched across all the resources. So they're just showing a whole list of resources you can purchase from the company here, but many of these we're using as well. In the future, we hope to be able to tap into this large reservoir, about 130 different handbooks from Lang and from other publishers that are all integrated into the search engine. At this point, we're still working with a core library. So many of you, of course, are using these kinds of resources here, on your own smartphones. How many are using, smartphone-based? There's most of you, right? Yeah. And so it's not very unusual for us. We know about these and have been using them for a while. But it is something new and novel for most of the Kenyan and East Africans that I'm working with. They just haven't had access to it. And part of the access problem is they can't pay for it because they don't have credit cards. They don't have access to a bank credit card to go online and purchase something and so forth. They use their local phone payment system, M-Pesa in Kenya, which is what we're using for the payment system here. So those are some of the other barriers that come in the way that are slowly being broken down, but slowly. So so we'll talk about that in a second, but basically it's either way. Yeah. So can I just go down? Yeah. Okay. So it's got bookmarks, and you can put notes on every page that transfer after you put in a new edition of the book. So there's lots of features of the product underneath it. So we basically are rolling this out right now in Kenya, and this week a person from Ahmad University in Somaliland is taking a bunch back to them. South Sudan, Uganda, Rwanda, and Tanzania are on our list to try to get to before the end of the year, and then other Anglophone countries that we've made contacts as well. So our goal is to get it to the students and residents because they're the ones that are in that steep learning curve, as well as those of us coming right out into practice, or all of you that are going to potentially work in a setting in Africa would potentially use this as well, although it's not, you can't find it or download it from the Google Play Store from here. And that's because it's built in that your Google address is tied to America, and we only let this be seen by Africa. And the reason for that is this. Cost. This is $1,100 worth of resources on your phone for a $45 subscription per year. So it's about a 10% or 5% cost. That's the negotiating that I've done with all these suppliers, which have been very generous. They've said, you know what, this fits our mission. We want to help you. We want to help see that this happens because we're not making sales in Africa anyway. We might as well give you it at 5% and see what we can do. So that's what we're up to, trying to see what we can do. And we have to bring it up a little bit over the years. Hopefully people are tied in and want to keep using it, and we'll hopefully pay a little bit more as they keep going. But our goal is to keep $60 per year as our target ceiling price. So it's basically been the work of the Institute of Family Medicine, which I directed for a while, and this is some of the other things that InfoMed has been doing to try to help support the capacity building across Kenya Association of Family Docs, and we started the Eastern Africa Health Professions Educators Association, and as Shiley was noting, just a couple of weeks ago, starting the College of Family Medicine for Eastern and Central Africa, so we can develop some standards around primary health care training. So that's the work we're up to, and hopefully it's something that you would find useful and interesting for your colleagues in the future. And the only problem is that you're not supposed to bring it back to where you work on this side. When you're done, you're supposed to expunge it, and we haven't figured out how to make you do that yet. But it is something that's important to us because the people are being very generous to allow us to do this. And if it becomes pirated into Europe or America, our basic platform for being able to distribute is destroyed. So it depends a little bit on honor. We're doing all we can on the programming side to make sure you stay honest. But it doesn't. There's no law against having a smartphone that stays in a site where you're connected to, so that the next person can use it when you leave. That kind of thing. Leave it behind. That's certainly possible. So anyway, those are some developments. It's taken 10 years to get this far, and we're hoping that we're going to see this mushroom in the next year or two, and hopefully we can see information helping at the point of care. So any questions at all? Shiley, how many minutes? Okay, yeah. Oh. So CDC then connected, or? WHO. WHO, okay.
So one of the major inefficiencies in the government programming is around retraining. That the education, the Ministry of Education and the Ministry of Health are very separate, very hard to cross that bridge.
Mm-hmm.
Very hard to get the medical schools to train the new physicians, the up-and-coming physicians, using treatment guidelines that are consistent with the Ministry of Health.
Yeah.
And so they get out, and so then the programs have to spend dramatic resources, financial and human, retraining the So I was really intrigued that you've included the Ministry of Health guidelines, especially right now for HIV treatment.
Yeah.
So my question is, I'm just wondering if you're getting much pressure from the ministry, or kind of excitement, I would hope, by the ministry to have the inclusion of all of the treatment guidelines in this app. But my question was more. I think I would expect that you would receive some requests to remove other inconsistent treatment guidelines that may appear in other sources. So that's one question. And my second question was, on your surveys, were you surveying people in the public sector or the private sector, or both? Because they do behave very differently.
Quite different, yeah. Yeah, so the first question, Ministry of Health, I met with the new Director of Medical Services. This is
Bruce,
the people I connect to.
Do you mind just repeating the question?
Okay, sorry. The question is basically around the Ministry of Health, and what interest do they have in what you're doing, and in terms of expanding their availability of what they do, into this library. So my premise is this, that as much as I would teach and preach an evidence-based medicine approach, for which essentially all of these resources are trying to be, all right? So you have narrative-type things like handbooks, but then you have Dynamed, which is about the most evidence-based thing I know of in terms of being able to evaluate, for yourself what actually is there. For all that said, when you're talking about medical officers, clinical officers, and nurses, they don't get evidence-based medicine because they're taught very strictly that you follow the guideline. This is what we have done. We have done an evidence-based guideline, and you will follow that because that's the way we want you to practice, and that's how they're taught to be a guideline-driven approach. So for the most part, that's true. I mean, the treatment guidelines, 2012, I think, are the most recent guidelines, so they're actually reasonably up to date given what could be there, which would be 15 years old. So, of course, there's going to be discrepancies all the time based on current evidence and what a guideline might say, but getting the change in education from evidence from the authority-driven resource to an evidence base that's a paradigm, that's a cultural paradigm shift, and that's generations in my book. So at a postgraduate level, I'm trying to teach family medicine residents, and just got done doing their opening course on this, so that evidence is what they at least know how to use, and hopefully will interpret that in light, a guideline in light of what they can look up for evidence. And they're excited to do that. But when I would poll, when I was medical director at Kajabi and did the Journal Club and found an article in Canada that would use regular gloves instead of sterile gloves to sew up your laceration, okay, let's do that. I'm the medical director, you're my staff, let's go ahead and do this tomorrow. And they said, no way are we going to do that, Dr. Dahlman, not a chance. Why? Because the Ministry of Health hasn't said so yet. And that's going to be the bottom line. All right? This is with people that know how to read an article and critique it well under evidence-based medicine standard, can see the difference, but won't do it because they would not be following the Ministry of Health. So what do? We teach evidence and we change culture one slow minute at a time. Second question was? Public-private. So all my study with 8 residents was in, 2 were in the church hospital, Kajabi, where I was. 6 were in the government hospital, Webuye. Rwanda was all in the public sector. And in the latest study, 160, they were basically all in public universities levels, yeah. Mm-hmm. Yes, sir.
Do you have any relationship to the Aga Khan?
Do I have any relationship to the Aga Khan? I have lots of good friends at the Aga Khan University Hospital.
What I'm asking is, my former student is a CEO, and also in DAR.
Okay, yep.
And I think they would be supportive of this.
They have been already.
The foundation is really pretty good.
Yep.
And,
Yep. So we've been in these pilot studies. I'm staying under the radar as much as I can. And so the family medicine, so the family medicine residents at Aga Khan have been using this as part of my study. Okay, they were part of the Kenya group that was studying it, and they will be receiving this shortly. We just got the registration module kind of updated last week so I can actually talk to them about it. And once they're going to be able to register without being frustrated, it's going to catch like wildfire is my prediction. So they will get it. Yes, thank you. Mm-hmm. Yeah, so the CEO, you're talking, that it was your student?
Yes, he's now in DAR.
Okay.
He was in Nairobi.
Okay.
In Mombasa. His wife is the head of nursing in Nairobi.
Okay.
And
Okay. And the name? Remember?
Shabutan.
Okay. All right. Okay. I can't. I'm not sure I know that person. Okay. All right. Good. One more question. Okay. All right. Yeah. No, Aga Khan's been doing a great work across all of East Africa. Any other questions? So I'll go ahead. That was U.S. dollars. Clinical officer's wage, to be comparison maybe, would be around $150. Let's see, 15,000, 20,000. Yeah, about $200 a month would be their wage. So we're asking for 15% of their 1 month wage. They buy their phone for about $100. So we're asking about a third of what they're buying their phone for. Yeah.
One more question.
I know of other models in which products are sold at a premium cost in the developed world and then subsidized in the developing world. And I just wondered, why couldn't Medhan sell this product, at a extremely, a partially elevated cost, and then provide it for even lower in the developed world?
Yeah, in a sense, they're doing that. They're doing it by just individual subscriptions to books, but not the core. So what we're getting the cost to produce cheap because we're packaging the same for everybody, and then trying to pick by the research we've done what they're going to need. And so far, people are telling us we're picking things that they're finding useful. But really, I think it comes to a philosophical decision. Africa should pay for what it's using, just like you want to do too. All right. It gives, I think, pride of ownership to see that they're actually contributing to what they're using. And that's part of why we're doing it. You can hand things out, and I could go to big donors and ask for money to actually dish it out, but I'm staying away from that. I want folks to value what they have. Yeah. So if you want to talk more later, I'll be around and hang around. I did put my cards in the back so you can get to the website, at least to look it over. You can see the website, but you just can't see on Google Store. You won't see the download because it's not available for you. But if you get to Africa and have an African-based phone with an African signed-up Gmail account, then you can see it and download it. Okay, it takes those 3 security steps to be able to get into it. All right, thank you very much. Yeah.
Thank you, Bruce.
Sorry, again? So anywhere across sub-Saharan Africa, even Francophone Africa, we've made it available to Francophone, even though obviously we don't expect a lot of sales there, but there are some. Yeah. Okay.
Thank you, Bruce.
Yep.
On Mfangano Island. This is my first time attending this series, and I can see that I'll be coming to many more. This is great. The presentation I want to give today is a little bit of background on my work as a medical anthropologist on an island called Mfangano in western Kenya, out in Lake Victoria, and a little bit of the history of the organization that we've started there, and our vision to build a community health ecosystem to serve this community and serve as a model for similar communities facing similar challenges, like so many of the places I'm sure that you visited. As Dr. Prasad mentioned, I was fortunate to have an opportunity to study medical anthropology, which for me is really what kind of brought me into medicine. I wasn't sure I wanted to be a physician when I began this journey, but my experiences in Kenya helped confirm that. And part of my part of the kind of the theoretical work that underpins a lot of my ethnographic work in Kenya is, around the idea, looking at different ways of thinking about disease. And I think that one way that we're quite familiar with here in the West is this social determinants of health model. And I think when people try and ask me the question, like, what is medical anthropology, that's often something I think that people kind of quickly understand, this concept that medical anthropology looks at the social, the political, the cultural, the historical factors that influence the way we understand, experience, and practice health around the world. But for me, there's kind of a fundamental problem with this model in that the whole framework is set up as this idea that there are these social factors, these social and cultural things, ecological things that are happening, and they influence risk factors, but that disease still remains actually something that's physiological. It happens within our bodies. And so when I began my work as an anthropologist, I really wanted to look at some different ways of thinking about it. And in fact, I really liked what you said, Dr. Dahlman, when you mentioned that much of the world is the relational world. And I think that around the world, I think people have different understandings of the way that physiology works. And I think some of the things that I think maybe are perhaps a bit radical for medical anthropologists, I think are taken quite naturally for people all over the world. And one is the understanding of what is an organism. And I think for all of us who go through medical school, we're quite familiar with kind of the neo-Darwinian concept of really an organism as a physical entity that's bounded by lipid membranes, largely governed by DNA that represents its genetic heritage. I think that an alternative that is actually really important when we look at global health is one that I found articulated very well by an anthropologist named Tim Ingold. And if you ever want to read something that really will blow your mind, his essay, An Anthropologist Looks at Biology. When I first read that, I don't think I slept for a couple days. It was really, for me, really clicked something. And I don't think he's read it all probably in medical circles. He's worked with Arctic hunters in Canada and Finland. But he describes an organism as a locus of growth and development within a continuous field of relationships. And thinking about organisms in this way, I think, is really important as we try and tackle the social, the ecological, the socioeconomic, the political factors that influence disease. And I think brings it into a framework where we can really say, actually, this does relate to the physiology of disease. I think a framework that I actually just heard recently, someone showed me a TED Talk just in one of our didactics programs in residency about the ACEs study, where we're looking at early childhood trauma and the way that that influences the physiology of kids that are exposed to domestic violence and substance abuse and psychiatric illness early in childhood, the way that impacts their health throughout the rest of their lives. And I think that is a framework that I think fits very nicely within this. And that's saying something different than those risk factors influence their risk for obtaining those disease. It's actually saying this is part of the social pathology or the etiology of this disease. Anyway, I'll tell you a little bit more about how I attempted to apply this framework, but really it kind of happened retroactively. I think my experiences in Kenya kind of informed some of the things I was reading in these dark libraries at Oxford and vice versa. And I want to share with you a story about a nexus of relationships. And the way that Tim Ingold describes this, his framework, is that an organism is really the infolding of relationships, whereas what we might consider an ecosystem is really the unfolding of those relationships across a landscape. And I think that when we look at HIV in Lake Victoria, for me it became apparent that this is really an appropriate way to understand that epidemic, which in the communities where I work, where HIV prevalence remains around 30%, one of the most impacted populations on the planet. And for me, it relates to the story of Nile perch, which I'll talk with you a little bit about. Sounds like many people in this room have actually probably been to Lake Victoria or nearby. I work in a place called Suba District, which is in the far western part of Kenya. It's right on the boundary of Uganda and Kenya. And in fact, Mfangano Island, where I work, it's one of the largest islands on Lake Victoria. And it's literally on the boundary between Kenya and Uganda. Some of the outlying islands are actually disputed still, depending on how well the Nile perch catch is doing and which government feels that it has claim to the tax revenue from that. But it also means that, as you'll hear, neither government feels particularly responsible for this constituency, in part because it's such an itinerant community. People from all over Africa live out in Lake Victoria. And that has meant that it remains under-resourced, to say the least. My experience began here with a serendipitous crossing of paths. I had an opportunity to work after college with an organization called AMPATH, which probably a number of people are familiar with. Started through the University of Indiana in Eldoret, Kenya, and actually has grown into a wonderful consortium. And I worked in the community mobilization department for about 7 months. My first experience with HIV in East Africa. But at the end of my time, and about maybe 2 months before I had to go start my medical anthropology program at Oxford, this was back in 2007, I made huge plans for my cross-African backpacking trip. I was going to try and travel from Kenya all the way to South Africa and have my big adventure. And I made it about 2 days to a bus stop. And I was standing at this bus stop, and I ran into what was actually a couple of Americans who had dropped out of college and decided to move to Kenya after they met these two gentlemen on the internet. A man named Richard Magarenge in the upper left there, and his uncle, Joel Aguta. And Richard and Joel had started the first organic farm out on Mfangano Island. And Richard actually had gotten trained. This story, I think, is great because I think it relates to, I think a wonderful story of grassroots development. But Richard was trained as a VCT counselor on one of the organizations on the mainland. And that meant that he actually had access to the internet, which was non-existent on the island. And he came across something called WOOF. Is anyone familiar with WOOF? Has anyone ever been on a WOOF farm? So it stands for Worldwide Opportunities on Organic Farms. And it's basically couch surfing for farmers or young people that want to live on a farm. And basically, in exchange for free farm labor, someone will give you a house and a place to stay. And so Richard convinced his uncle Joel, who had they'd started this farm together on the island, that they should register it on the WWOOF website. And my good friends and co-founders of our organization, two students in Oregon, came across their WWOOF site and said, hey, this is the spot, and packed up their backpacks and dropped out. And I was hearing this story at a bus stop, and I was saying, you got to be kidding me. And they said, well, hey, man, don't get on that bus to Tanzania. Why don't you come out to the island for a night? And it truly was a moment where I was about to get on this bus. I think I already had my ticket purchased, and I was like, all right, why not? And I think I've been hooked ever since. And really, this has become my life's work. And I love these people. I love this place, and I love this work. I'm sure as many of you have been connected to the places where you work. So that's how I got connected there. The story of the people who live on these islands I just found fascinating. Most of the people that live on Mfangano Island and the nearby islands are descendants of a group of people that came across from Uganda about 250 years ago, the Abakunta. And a lot of this history I started reading, and some resources that I found actually at the back of the Rhodes Library, which in Oxford has a lot of these really old colonial anthropological, to be honest, very racist texts from some early anthropologists from like the British Explorers Society. And that was some of the only resources I could find actually on the oral histories of these people, other than my friends Richard and Joel, who were telling me these stories that, to kind of my excitement, I was finding the same histories kind of documented in these old texts. And this oral history, basically, which I think someday should be made into an epic movie, is about the 26th king of the Buganda, a man who was assassinated by his younger brother, who kind of in this very Machiavellian scheme took over control of this kingdom, but with the help of two Suba clans, these two brothers that were warriors that helped him overthrow the king. And as soon as he became the leader of this new kingdom, he realized that he'd made these two clans very powerful, and he held a council with other clans to basically go and eradicate them. Fortunately for my friends on Mfangano and their ancestors, there was a court drummer at this meeting who heard this plan and rushed to warn his families, and basically sparked this mass exodus of people from Uganda traveling across the lake around the 1750s, fleeing from the new king and arriving on these islands. And actually, when I arrived on Mfangano, my friend Joel, I remember the first time, pointed to this tree on his farm and said, hey, that's the Kitawi tree. He said, one of our grandmothers is married there. And I was like, oh, that's nice. But then it was later at Oxford, I was reading one of these books and came across the fact that Kitawi, the woman buried under this tree on my friend's farm, was actually the wife of that court drummer, Mwembe. So my friends are direct descendants of this group of people, and most people on the island, the Suba people there, can trace their identity back through these stories. It's also one of the last places in the world where Suba language is spoken. Maybe about 100,000 native speakers still alive, which is unfortunate because it's also a place with, about 30% HIV prevalence, which is one of the major reasons why this language is disappearing. But about 30,000 Luo and Suba people live here. We probably are familiar with Luo because our president's father is actually from the Luo community. It's about a 2-hour boat ride from the mainland. Greater than 40% absolute poverty. I don't really know what that means. Everyone there seems pretty impoverished. But that's, I think, the official number. Although I would say lately I work in North Minneapolis, and I've noticed that, the way I think about poverty is different. People there are truly poor in terms of food that they can put on the table every day. But in terms of the strength of their relationships, they have an amazing resource in their families. And I think that's something our organization is working hard to harness. This is some data from 2009. When we looked at HIV prevalence there, it was around 24 to 28%, at least on this Sentinel survey. Some of the outlying islands, which I'll talk a little bit about, have HIV prevalence, I think, still around 50%. And that's because they're largely fishing communities with itinerant populations from around East Africa. Okay, so, the title of my talk was Nile Perch and HIV. And really my thesis as I kind of went through this was trying to understand how is HIV so prevalent here? Why, if you travel a few hundred kilometers to Eldoret, for example, where AMPATH works, and HIV prevalence is only 4%? what are some of the social, ecological, cultural things that are influencing this epidemic? And for me, actually, it all boils down to this fish called Nile perch. I mean, that's simplifying it a bit, and I'll tell you the story, but I really do think Nile perch is something we can point one big finger at least. And part of my work in kind of adapting what I was reading with Tim Ingold is this concept of parasitism or macroparasitism. I don't know if anyone's ever read the book by Peter Brown, Microparasites and Macroparasites. Another really fascinating text where he looks at the costs of malaria to farmers in Italy versus the costs of their tenant landlords who extract a huge amount of grain from them every year, and shows that the health consequences of the social system are way more deleterious than the health consequences of the microparasite in their blood. And I think that framework made a lot of sense when looking at Nile perch. Well, I'll tell you just briefly the story of Nile perch. In the 1960s, the British colonial administration looked at Lake Victoria and they said, this fishery is not nearly profitable enough. The species that live there are called haplochromine cichlids, which in the ecological literature are this unbelievable species flock that 300 to 600 species we think evolved in Lake Victoria in the last 14,000 years from when it was dry, which is this incredible speciation. But they're bony fish. They support the artisanal trade, but not an international market. So the British colonial administration said, we need to replace this species to create an export fishery, and they did, illegally, and they introduced Nile perch. And it took about 20 years for this species to really take root in Lake Victoria. But in the early 80s, I'll skip ahead here. These are pictures of cichlids. You've probably seen them in aquariums. They're beautiful fish. But in the early 80s, all of a sudden, the Nile perch exploded, and there was a huge boom. And basically, Nile perch is a top predator and a cannibalistic species that concentrates biomass. Went from representing something like less than 2% of the biomass in Lake Victoria in 1980 to something like 95% of the biomass by 1990. It's the single greatest mass vertebrate extinction in recorded history. Hundreds of native species went extinct in a 10-year period. And basically, you can see the trophic structure of the lake went from what was at the top, very diverse, to very different, almost entirely Nile perch in the bottom. And some of you, I don't know if anyone's ever seen this movie, Darwin's Nightmare. Documents this story somewhat about the ways in which, at the time, Soviet airplanes were actually landing in Uganda, dropping off arms, and then filling up with Nile perch and flying back to Europe. So it definitely contributed to a lot of violence and political instability. But my work has really been looking at the way this industry contributed to HIV. Not to mention, the ecological impacts really affected the eutrophication of the lake. The haplochromine cichlids played a really important role in nutrient mixing. That was completely eradicated, and we have huge overgrowth of hyacinth and different algae blooms. In Figano Island, I often say HIV is so prevalent there because the water offshore is so deep. And that's because it's some of the best Nile perch breeding grounds anywhere in the world. And it's at the ground zero of the Nile perch fishing industry. And these are just some slides that show the way this industry was never set up to benefit local communities. Almost all the value of the industry accrued in Europe to kind of national processing factories, and a very small percentage actually went to all these fishermen. Let's see, this is the slide that sometimes gets me in trouble, but I love showing, because this actually documents the increase in Nile perch you can see in the blue here on the bottom, which really began right around 1980 and peaked around early 90s, which exactly mirrors the rate of new infections in Kenya during that same time period. And the reality is that Nile perch during that period turned Lake Victoria into something like a gold rush. You had hundreds of thousands of young men from across Africa. Literally anyone who could get on a bus, show up, get on a boat, and grab a net was pulling hundreds of kgs of Nile perch out of the lake a day. The stories of people, just mountains of Nile perch. And I think that any place where you've got hundreds of thousands of young men away from home earning cash in extremely poor communities. And I think we've probably seen the same situation in mining industries and logging industries. You really have a macroparasite, which is really setting the stage for an opportunistic infection, a microparasite like HIV. And what we saw around East Africa was a boom in kind of a secondary industry. These were restaurants, these were bars, these were brothels. At the same time, in a community where women and girls never had the same economic opportunities as men, oftentimes one of the only ways to gain access to income from this industry was through forming relationships with fishermen, which wasn't exactly prostitution, but it was certainly transactional, and really contributed to the spread of HIV like few places. You can see here in Suba District, in 2003, HIV prevalence was around 40%. In nearby communities, you can see it's still high, but not nearly the same. So part of my work was looking at this concept that HIV on Lake Victoria weakens not only individual immune systems, but these social networks, these relational networks that people rely on, by reducing adult productivity and livelihoods, increasing the burden of orphans, decreasing income. One of the first things that happens in so many of these families is kids get pulled back from school, increasing medical expenses, decreased food security. And all of this contributed to something that I described as HIV risk induction. There's two authors, Christakis and Fowler, did this cool study on the way smoking spreads through. Actually, the first one they did was on obesity, the way obesity spreads through a social network through induction. And the reality is that HIV spreads through these social networks, not just because someone's uncle gets infected and is going to pass it on directly to them, but when a breadwinner in a family becomes infected, it affects the economic viability of a whole social network, and kids are getting pulled back from school, and people don't have the same food on their table. It increases the likelihood that women and girls in these families are going to be involved in transactional sex, tenfold. And that type of risk induction really accelerated the spread of HIV across these communities. This is kind of just a diagram that outlines that same kind of vicious cycle. And in Kenya, the term actually is often described as jaboya, which used to mean an anchor, and it was a relationship where a fisherman had a wife in multiple points, and he would stay with that family when he traveled around the lake. But since the emergence of now perch, it's much more closely translated as fish for sex, and it's more of a transactional, almost prostitutional relationship. So all that is to say that I think that looking at HIV in a context like this is much different than trying to understand the specific biology of the virus, trying to understand the specific medications that can treat it. And I think the goal of our organization has been to try and take that bigger picture look and try and apply some of these concepts, think about the relationships that are involved in this epidemic. And as Westerners, I think this kind of excited us. It seemed very different. But I think the reality is for people there, this is the way I think they've understood changes in their landscape and changes in their communities. And a few examples that for me stand out as an anthropologist. Tembea in Swahili means to kind of walk or to drift. It's used there colloquially. It often refers to relationships outside of marriage, to drift outside of your marriage. The interesting thing to me, though, is that the way that people describe the most extractive form of now perch fishing, which is where these guys float these miles-long nets outside of their boats that literally just siphon the lake. It's called Tembea fishing. It's the drifting fishing. And what's interesting to me, it's kind of semiotically linked between the way that there's these drifting now perch fishermen. It's the most extractive, most environmentally devastating form of fishing, and they continue to move through each community, these fleets of Tembea fishermen. But also the drifting that was happening on shore in some of these communities. This in the background here is a place called Remba, which literally defines the border between Kenya and Uganda. If you go there, it looks like something out of Pirates of the Caribbean. It's about 6,000 people that live in a slum on a rock, no trees, no health center, maybe 60% HIV prevalence when I was there last, and fishermen from all over the world. There's discos. It's a wild place, but definitely a place that I think is contributing to HIV infection across East Africa. Another is the example of jaboya, which I talked briefly about. And chira is another wonderful concept, which is a wasting illness that people have talked about for generations that you can bring about not only to yourself but to your whole family if you break certain cultural taboos. For example, sleeping outside of your marriage when your wife is pregnant, which I think in a lot of early public health work was really discredited. We tried to convince people that HIV is different from chira. But the reality is that they speak to some of the same concepts, which is when families struggle and cracks open up and there's opportunities for drifting, there's opportunities for serious infection like HIV. So our organization began when my friend Joel offered to donate a large piece of his land to build a community center. In fact, the initial idea, to be honest, was to build a library. And we started to have some meetings in the community about what would people like to see if we actually built a community center. I kind of naively at the time said, hey, sure, like I'm doing research here for a couple of years. I'll help you fundraise a community center. That doesn't sound too hard. And we got started. And with looking back with a lot of hubris, that this would be easy and that we could do it quickly. It hasn't been easy and it hasn't been quick, but it's been very fulfilling. And this is actually a picture of his land back in 2007 that Joel cleared for us. Oh, maybe I'm getting ahead of myself here. So basically, we talked to everybody in all these villages about what they'd want to see in a community center. And what we heard back over and over and over and over again was access to the internet. Access to the internet was what everyone was asking about. And so we said, sure, we'll provide access to the internet. Again, like how the heck we would do that out on an island, no idea, but we promised it. But we came up with this idea, and our idea was, this was the seed that really got us started, was what if we provide free access to the internet to any person in this community who agrees to learn his or her own HIV status? And we put permanent and full-time HIV counseling and testing in our center. And we create a club where anyone can come and use the center for free. You just have to sit with one of our counselors to get your membership. And in order to continue using the club, you have to sit every 6 months. And the idea being that we create an incentive that people can understand. But I think more importantly, because when I'm there, people they actually want to know their HIV status. They just don't want to be seen walking into the VCT center that says either I'm concerned that I've been sleeping with someone, or my wife has, or if I'm a clergy member or a teacher. In these rural communities, social suicide to be seen going in and out of the VCT center. So this created just an excuse that everyone basically could buy, which was, I want to use internet, I want to check my email. And that's what kind of got us started. And that got us kind of some of our first funding from places like Google, and actually Craig Newmark, the guy who started Craigslist, liked this idea and helped us out. So we decided to build this center, and we decided to do it ourselves. We wanted to give jobs to people there. We didn't want to hire outside contractors. And so we began working in 2009 at this point. And again, what I thought would take us about 9 months took us about 3 years. And in the process, we actually had to come up with a way to provide internet, which involved us trying to get access to a skyscraper in the nearest city in Kisumu and bouncing the signal out to a tower that we had to build on top of the island, and bouncing that down to the island. And again, that took up another 2 years. But the reality is we have high-speed like Wi-Fi out on the island, which is crazy. But now we have like Skype meetings with our staff there, and yeah, it's awesome. And people there use high-speed internet at our center for free every day of the week. Another thing that came out of this was interest in a Suba language radio station. And when we built this tower, we actually had an opportunity to put a transmitter up there and start broadcasting. And we did somewhat illegally for a couple years because there really was no way in Kenya to actually obtain a radio license after the political instability of 2007. And still, actually, legally, there's almost no way to get an official radio license. We kind of have a few unofficial workarounds, but it's something that our organization is working hard to solidify. But we broadcast to about 200,000 listeners in Suba along the shores of Lake Victoria each day through a wind-powered radio station, which is the only way we could figure out how to power this thing. In our community center, we've got about, well, actually, our latest numbers, we have about 3,600 members now that have joined this community center. And it's kind of the headquarters for what's grown into a community health organization with a much broader mission than just tackling HIV. Really understanding that HIV is part of some of the larger problems that this community faces, but really trying to create a place where local community activists can come, get organized, develop their own ideas, and in a sustainable and resilient way over time address the needs of their community. And I think we're kind of harnessing, some of the energy that exists right now for addressing HIV, or I think the next big thing is probably, at least what grant funding that we're chasing these days, is like family planning and reproductive health. Those are important needs that exist, but we're trying to grab onto some of those resources that are available and build long-term infrastructure that this community can use to tackle whatever the next need is going forward. We think about our organization kind of as a tree. The EK Center is our trunk, and the community itself really are the roots. And then these branches, we've actually changed a little bit. Kind of the branches of our organization are specific programs that we implement, but we think that they kind of provide shade for a whole garden of other local ideas people are developing in the community. And we really have kind of embraced the idea of mission drift to the extent that we think that diversity is really important, and that, skipping ahead here a little bit, our organization, I think, is really embracing kind of a permaculture approach to global health. And I think this comes out of our roots as a wolf farm, and now it really is a permaculture center of learning. But if you're familiar with the permaculture concept, it's really different from monoculture. Monoculture being the large cornfields that we have, across the Midwest, where we focus on one crop, which I think is maybe also analogous to like a large vertical intervention that we have in global health. I think a permaculture approach is really this idea of taking a long-term, locally based strategy that's diversified, that the inputs from one program actually support the inputs of or the outputs from one program support the inputs to the next, in a way that our radio center we try and use to mobilize and use information across the area, and it provides a platform and a way of disseminating information about HIV. This is an example of our emergency boat, which actually we now provide the only ambulance service for about 30,000 people on this island. Here they're actually using it to, we're bringing over tree nurseries for some of the tree nurseries that we've started. And I think our concept has really been this idea that by going slow, by taking our time, by iterating, by really letting our community lead, and by staying small, that we have an opportunity to make a big impact over time. And I think those are some of the ideas we hope to share with other communities. Not to say that large interventions and scalable interventions are not important. They are critically important. But I think our approach is going to be slightly different. I think we're working hard to try and really develop a collaborative vision with our Kenyan partners, and to try and walk that walk. I think we found over the years we kind of go back and forth. It's a pendulum. I think there are times I think we really live up to that ideal of making sure that the things that we're doing are community-driven. But I think there's also times when we've got lots of smart Americans with, excellent degrees and who are very capable and are able to do things and say, this is how we should do it, and we do it that way. And I think we're wrestling with that a little bit, about how do we balance that? How do we harness the energy that we have from talented people that are inspired and want to help, but also making sure that it's really important that people in this community figure it out and that go through the problems themselves, go through the failures themselves. And I don't think it's an easy question. I'm sure anyone that's done this knows that much easier said than done. I think the rhetoric out there is we all agree, let's make sure it's community-driven. Trying to find a way to do that on a day-to-day basis is really hard. And I think that's something that our organization is embracing. Give us maybe a B+, A-. We're doing our best. But I think it's something that's really important to our mission over time. And I think we're in this for the long haul. I think somewhere along the line I realized this was my life's work. I think for my Kenyan counterparts and co-founders, this is certainly their community where they're not going anywhere. And we recognize, I think as you said as well, some of these changes are not things that we'll necessarily see, hopefully some of it in my lifetime, but I think it's also about generational change. And I think taking that long look and really saying it's not about this grant cycle, it's not about the next. Well, one, it's easier to deal with frustrations and setbacks. But two, I think that's really where we're aiming. So I think I brought it in before 8. But yeah, I wanted to give a chance for any questions. I didn't go into details of some of our programs. I'd invite you to visit our website, the Organic Health Response, and take a look at some of the specific programs that we're implementing. And happy to answer any questions. If you're ever in Kenya and are interested in coming out to Mfangano Island, it is a long journey, but you'll be welcome there. Thank you very much for having me.
The rate of HIV among men who have sex with men is very high in that area in the whole of Western Nyanza province. And I'm wondering whether that's something you have come across and how you deal with it in your organization based on the cultural differences and the stigma.
Wow, great question. I'm sure that the prevalence is very high among men who have sex with men. I think it's not something that's spoken about very much at all, as you're probably familiar. I wouldn't know specific details about that. And I think that's been an interesting thing also, I think, as we try and look at adapting some of our own cultural values here in the U.S. and trying to apply them to the way that we do work in this place. I think it is truly a very Christian community where we work with, I think, very conservative values. I think we have a unique opportunity in this radio station, which largely is run by youth. We've recruited journalism clubs from area secondary schools, which form kind of the bulk of our reporters. And I think that is an opportunity, I think, for a new generation to spark these conversations. And actually, I think the radio, especially in vernacular language, is such a powerful platform still there. I mean, the internet is great. Cable TV, where it exists, I guess, is probably awesome. But radio is still really powerful in these places. And I think we have a great opportunity to start some of those conversations about the way people think about homosexuality, about the way they think about gender equity, which is really a big problem. I think it's something that we will embrace, but also certainly cautiously and slowly. Trying to be, again, that's part of that walking the walk about how do you take the lead from a local community without forcing your own values. It's not an easy answer. I don't know if that even answers your question. Certainly a need that exists, and I'm sure that community is underserved in Kenya.
So obviously you're keeping a long view. You're getting started there. You're thinking about HIV, and then you're putting down cement foundations and stuff like that. So during that whole time that you were creating the center, were you able to do anything specific about the HIV piece, or was that really just something that just had to wait in the sense of the way we normally think of doing something about HIV? Obviously, you were doing something about it because you were improving the...
No, thank you. I didn't have a chance to go into detail, but I'll briefly summarize a program that very specifically addresses our approach to HIV, which is called the Mfangano Health Net. And actually, we just published some of our first results this year in the Journal of AIDS. And basically, this program really comes out of this idea of, instead of treating HIV as an individual infection, our goal is really to treat HIV-affected social networks, recognizing that it's a burden that affects these social networks. We designed a program where basically we recruited social networks that exist in the community. So community groups, church groups, sports teams, self-help groups, but also extended families. And working with the UCSF and Ministry of Health clinics there that provide antiretroviral medication, we recruited just over 100 patients from one part of the island and about 300 patients from other communities around the island to serve as our control communities. And implemented this program where basically we asked members of these groups, knowing that about 30% of the membership was infected with HIV, to go through a bi-weekly training with us, where we basically went through everything from the biology of HIV to how to work well as a group. And over the course of 6 months, they were trained together to really try and keep all members healthy. And at the end of this period, they were encouraged to actually go through group counseling and testing together. And was one of the first and I think largest community-wide HIV disclosure interventions of its kind. We had about 86% of our participants completed this group HIV testing and disclosure process. And ultimately what we were able to demonstrate was that we could cut loss to follow-up in half, so that people that were involved in this program at 22 months of follow-up were about half as likely to have defaulted from care as people living in our intervention communities. And we think that's in large part because people recognize that they have a vested interest in keeping family members who are infected with HIV in care, and that they're able to apply some of that positive social pressure and apply some of that support that's available when someone has malaria or a bad pregnancy or a car accident, but that doesn't exist because of the stigma of HIV. And we think this program can kind of help change that. And it's a program that we're actually scaling across the island right now and looking to bring to some nearby communities as well. So that's one specific HIV program that we've implemented.
Thank you. So you mentioned that I'm a little familiar with the area that you're talking about. I'm from the Rift Valley region of it, and I'm just a little curious about why that island or that specific area, which is nearby Kisumu, which is a little bit more of a town, a bigger town, does not have a higher community viral load in terms of HIV. compared to why it has that compared to Eldoret, which is also sort of like a tracking business environment similar to around that Lake Victoria region. So I'm just trying to figure out why does it have? Is it because it was, I don't know, the history of HIV around towards the Uganda side? Is it because of that history, or is it more because of the political in terms of the rift between the country, Kenya and Uganda, about that region? So they're under-resourced, underserved in terms of HIV resources. Because my assumption, and I'm very crude about this, is I would assume Kisumu, which is just right next to it, would have a higher community viral load compared to that region because it's a higher, it's a more metropolitan compared to the island. Thank you.
I think it's a great question. I think there are so many different factors that contribute to the epidemic. I think for me, the simple answer is that species of fish. I really do think that the way that international fishing industry expanded across Lake Victoria, and you're right, the first reports of HIV in Africa come from the shores of Lake Victoria in Uganda, when people first started talking about Slim disease. But I think that all of that really emerged right at this time when there was this huge boom going on in Lake Victoria. And I think one difference between a place like Mfangano Island, which is extremely poor and extremely rural, was that there wasn't a diversity of economic opportunities. Whereas a place like Kisumu, well, I think the same things were happening. You definitely had fishermen, you definitely have trade routes, and we've seen that across countries all over the world. I think that phenomenon is happening. I think it was much more, it was accentuated on a place like Mfangano, where there really were no other economic opportunities, entirely subsistence community, and all of a sudden there's an international industry at their back door. And I think that paired with the fact that governments were not looking out for that constituency. Well, despite the fact that GDP in Kenya was going up because of this industry, there were no new schools, no new hospitals, no new roads. The first bank in this region opened up in 2005. So really no even opportunities for local businessmen to try and translate this economic opportunity. So I think some of those pieces, the same phenomenon that's happening all over the place, I think were highlighted and accentuated in a place like Mfangano. And it's also an island, so perhaps it's easier to see there.
Any other questions?
Great. Thank you very much.
Thank you, Chas.
Still connected.
There has been a movement in global health. There's been a movement in global health to move from single disease approaches to more community-based health systems, primary care / public health-based approaches. So hopefully these are two models that you will be looking at. We'll probably see more of these come up. So I'm excited for the opportunity to do that. Thank you all for coming.